I know I mentioned this many times. When I was finishing up my medical training, I was originally, my thought was I was going to take over this primary care practice, and it had two urgent cares, about 4,000 patients, and it was with a doctor that really cared about his patients. He would spend as much time as somebody would want and or would need. Downside of that was that there were a lot of people waiting in the waiting room. They were really pissed off. So it's the pros and cons. And I just really liked the small town doctor. He would always be there. He would check on patients even in the hospital. That's unheard of these days. But that was what patients really appreciated. It was that long-term relationship. The doctor always showed up to the appointment. It wasn't just a rotating door of folks that really didn't know your situation. And I felt that was a really great way to still practice medicine, because the other positive side of that is that things don't get missed as much. Because a lot of times with handoffs, if somebody doesn't document something and you're dealing with a big team, which big teams are nice a lot of times, but sometimes things get missed. One person doesn't tell another person something, and things can go really wrong. So one of the models that's been developing is called direct primary care. And a friend of mine who she was actually my resident when I was in in medical school. She ultimately opened up a successful practice in Rhode Island, and we worked together in terms of referring patients and so forth. And she was one of the pioneers of this direct primary care movement. And this is something that I realized could be a very big part of our healthcare system moving forward. And I wanted to talk about not what it is. There's plenty of information on what direct primary care is, which is you subscribe to your primary care doctor instead of using insurance and going in and your insurance paying per visit, and maybe you pay a copay. You just subscribe, whatever it is. Could be I've seen as low as $50 a month. Average tends to be somewhere around $100, $150 a month, and you get unlimited access to a primary care physician who knows you. And I think it's a great way to go, and here's why. So when I was working and helping that practice, that primary care practice, we were a small practice. The receivables, again, I'm going to estimate some of these numbers. I don't want to share anything too confidential publicly, but let's just say it was somewhere around $1.5 million in receivables every year. So that means that the practice, with all the billings, with the 4,000 patients and people coming in, doing the services, doing the small procedures and so forth, took in about $1.5 million. But there was a lot of infrastructure. So $1.5 million, to a lot of people, it's a lot of money. We had 3.5 staff that we had to keep, because you need somebody to answer the phone, somebody to process paperwork, some redundancies, and so forth, and medical assistants to help with prep and so forth. So 3.5 people, average salaries, health insurance, all that in, and ended up becoming somewhere around let's just round up, $300,000. And then on top of that, you've got the billing, the 10%, the rent, you've got the malpractice insurance, and then you've got also a lot of these also ancillary costs. So at the end of the day, the docs were really taking home somewhere around $2 and change, it's a good living. Trust me, it's a good living. A lot of people will be very happy with it, but the amount of work that was involved, it was 60, 70 hours a week on average of work, and a big part of it was documentation, and we're implementing an EMR, EHR, and that was a very complicated process. So at the end of the day, the margins, your two docs, top line 1.5, they were taking them, really, let's just say $250 a piece, so 500. So the margins, 66% cost on the practice. And it was working night and day. It was hard to take vacations. It was a grind. But here's the other thing, is that we never felt like we could really spend a lot of time with patients. I was in my training, so I could spend as much time as I want because I wasn't getting paid. But the average time was still like 15, 20 minutes. And if somebody needed more time, he'd stay for 30 minutes, and then that means, again, a lot of upset people. So it was just a really, 4,000 patients, let's say 2,000 patients per doc, and there's always walk-ins and urgent care and so forth. So that wasn't the total number of patients. The total number was probably more, but 2,000 patients, and let's say half the time was documentation. That means that you could really allocate 30 minutes a year to somebody. And a lot of these folks, they had heart disease, diabetes, they need quarterly check-ins. That's why all the docs, they were working more than 40 hours a week, because they needed to put in that extra time to be able to handle all those patients. Really hard to do, and to keep all those patients straight in your head and stuff like that. You really have to have a memory of an elephant. So let's flip the coin to our primary care model, which is you get rid of all the administration. So it's just a subscription. It's cash. You don't take any insurance. And what happens there is that those practices, a lot of times, they will cap themselves out at 300, 400, 500 patients. That's it. So that means that, let's just say, for the sake of round numbers, it's $1,000. You as a patient pay $1,000 a year to go to a direct primary care doctor. $80 a month. So $1,000 a year, and let's say that direct primary care doctor has 500 patients. So revenue-wise, $500,000, a third of what the clinic was taken in. So you're like, oh, well, top line, you're not making that much money. But you don't need any staff. You use like a Calendly to schedule appointments. You use electronic medical record that you don't need to do any of that billing. So it could be a really lightweight electronic medical record, really inexpensive, maybe $50, $100 a month. A lot of these guys, they will share an office space with another doctor. Might be $500, $600 to rent a room a month. Malpractice insurance, probably the greatest amount, $14,000. And there's a lot of expenses you can write off too. If you have a vehicle, a lot of these doctors will do house visits because now they have the time, right? You write off your car, you're gonna do house visits because now you have the time to do so. And 500 patients, if you're working 2,000 hours a year, you can allocate 4 hours per patient per year now. And because you're not doing any of the administration, billing, and all of that is minimal, out of that $500,000 you're taking in revenue-wise, your expenses might be like $80,000. That's it. That's even on the high side. So let's just round up even higher, $100,000. So with the $14,000 for malpractice, $10,000 for, let's say just round $10,000 for rent, all that stuff. It's hard to get to $100,000 per person without any staff. You don't have to worry about payroll. You don't have to worry about workers' comp. You don't have to worry about any of that stuff. And you're still taking home $400,000 a year, which is almost double what the docs in the clinic were making, still as owners. So you make twice as much, you have a fourth the workload, and you're able to spend more time with patients, able to do house calls, able to check up on them. So I think it's a wonderful model. And that's why this model has grown to over 2,000 practices and has been growing on average 35% or 36% last year in 2024. And it continues to grow. I think this is going to be a model that we need more people doing because it delivers greater care. And I've seen, my friend Lauren, she takes somebody that's maybe on 15 medications because they're seeing 8 different specialists and saying, let's sit down for an hour, let's go through these. Okay, these have contraindications. Do you really need this? Can we do these lifestyle changes? And a lot of times she's able to bring people down to 3 to 5 medications and sometimes completely off their medications. What savings is that going to bring to that person? Not only savings, but just quality of life. I don't feel like a zombie all day. And it's just, I think it's a better model. And I think a lot of people are paying attention to this. I think it's going to be a great thing moving forward. And it's funny, the adoption curve, right, for somebody, which is, I remember, it's probably a bad example, but I'm going to say it anyways, because it's the one I remember from the top of my head. I went to high school with somebody he was a really nice guy. He was like the Abercrombie and Fitch model, and I was like the ugly duckling when we hung out. And he would do a lot of steroids. Like he would be a body, great shape. I don't know how he's doing now, but would take a lot of anabolic steroids. And anabolic steroids do have a function. We realize that anabolic steroids are actually some of the studies have shown to be very good with wound healing, not just, bulking up. But so what happens is that a lot of times the adoption curve goes the fanatics that are like, probably shouldn't be doing this. And then you have people that with money that'll pay for it because, all right, for this application, it's effective. And then it works. And then it goes mainstream. And then it's covered. And then it's, it was evident. Just like the guy who, I forgot his name, but he was a doctor. I think he ultimately he was jailed for life or executed because he said, we should wash our hands in the hospital because if we don't wash our hands, the rate of infection goes up. And he was executed because that's what people are like, oh no, you don't need to wash your hands. You're gonna be fine. So there are so many things that are happening now that are going to be seen as evident in the next 10 years that today we're just adopting. And I feel like this is one of them because again, it's the people that really believed in it when it's like Apple, right? Like people that first believed in Apple, it had no integration, it had very little software, but people loved it. And then it became the people with money bought it, and then public adoption, and then dominant player. So I think this is a trend that we're going to see in healthcare. I think direct primary care is going to be able to reduce a lot of costs, reduce a lot of redundancies, and also really improve the patient experience and maybe get some of the docs back into the system that otherwise would have not wanted to practice because of the bureaucracy and the headaches that comes with running a traditional practice.